like any disease process, Kemal, it all has to do with understanding the severity of the disease, right? So when we talk about weight-related, disease, we talk about different degrees of severity of the weight issue, right, Kemal? We talk about somebody being overweight if their body mass index is, between 25 and 30. And then we talk about class 1 obesity if the body mass index is between 30 and 35. We talk about class 2 obesity if the body mass index is between 35 and 40. And then over 40, we talk about morbid obesity, right? The clinically severe obesity. So obviously, the levels of morbid obesity can be variable as well. You can have somebody with a body mass index of 45. You can have somebody with a body mass index of 60, as you say. We see patients even with higher body mass indices than that, right? So the question is, what treatment is appropriate for which body mass index? That would be one question to answer. Clearly, if somebody has class 1 obesity, a body mass index of 32 or 33, Kemal, that patient could do very well with a medication like Ozempic or Wegovy or Mounjaro to get their body mass index within a normal range, and they will achieve that, right? So that would be an appropriate indication. In fact, even before the appearance of these medications, currently, we don't consider somebody with a class 1 obesity as a candidate for weight loss surgery, right? We talk about surgery being appropriate for severe forms of obesity. So traditionally, surgery has been indicated for people who have a body mass index of 40 or over, or sometimes a body mass index greater than 35, but with the development of illnesses like type 2 diabetes, high blood pressure, or sleep apnea. So clearly, the place of medications to induce weight loss would be best suited in places where we are looking for modest weight loss to achieve the results that we wanted. As you correctly said, if you are 210 pounds and you're 5'5" or 5'6", if you were to get a medication that reduces your weight by 30 pounds, that would be a good result. There is no question about that. But if you are 300 pounds, if you are 350 pounds and your body mass index and your height is still 5'5", Kemal, losing 30, 40, or even 60 pounds with the best results that have been reported with medications, you would still be very, very high in your weight, right? If you are 5'5", with an ideal body weight of 150 pounds, but if your current weight is 300 pounds, and let's say you get, the most effective medication right now would be Mounjaro, right? Which has been reported as showing up to 20% weight loss in some patients. Well, with that result, somebody who's 300 pounds would be losing about 60 pounds. If you're 5'5" and lose 60 pounds from 300 pounds, you would still be 240 pounds. Come on, you would be at least 100 pounds away from your ideal body weight, right? So when you look at bariatric surgery, that same person could be losing, double that, up to 100, 120 pounds, which would bring their weight considerably lower. So for somebody who is with that high of obesity, clearly, even with the most effective medications, they would be better off with bariatric surgery. There's no question about that. That is really what the facts are right now. Come on. Having said that, patients may still be reluctant to undergo surgery as the first option, just because, people have different notions about what bariatric surgery may be, but also because they themselves need to be comfortable with the idea of surgery. So even if a patient with a high body mass index, if they are not ready to have surgery, I think it's appropriate for them to still have medications as a way to at least counter what they have right now. Even if they have modest weight loss, it's still better than not. But also it may be protecting them from further weight gain as well. However, there are limitations with medications as well. First of all, you have to be on those medications on a continuous basis. The minute you stop the medications, the weight tends to come back, right? Also, there is tolerance of these medications. People may have side effects related to problems with gastrointestinal symptoms, whether it's intestinal cramps, whether it's nausea and vomiting, or even more serious problems like pancreatitis. They can occur with the medications that may not make it suitable for a person to have those medications. Having said that, there are obviously complications with surgery as well, and we talk about complications in our sessions. The complications of surgery tend to be much more defined, because now we have how much experience we have with weight loss surgery. Come on, 40 years. That's a long time. And bariatric surgery, because it had to go through so much scrutiny to legitimize itself, bariatric surgery is probably one of the most heavily studied disciplines in medicine, right? We had to make it really super safe for us to legitimize the discipline itself, right? So we have 40 years of experience with bariatric surgery, but with the newer medications, we don't have that much knowledge come out. Our knowledge is obviously limited to the periods it takes for the trials to occur. So they have their own place. For modest weight loss, clearly medications will be appropriate. But when you have somebody who's struggling with body mass indices like the one you're mentioning, clearly the most effective treatment that we have remains still bariatric surgery.
So, yes, last night actually, I learned that my BMI is higher than former President Trump's. So you're supposed to be kind of like surprised after that. So now the reason I'm mentioning this, he self-reported his weight. So his height is. He self-reported when he was.
Oh, okay. Yeah. Now I get it. Yes. Okay.
So, people know by now that we don't rehearse these things, so you don't know what's coming. So,
of course.
When I saw, this is a politic news, but then, from selective side of me, I look at the height and weight, and he's apparently my weight, and then he's 2 inches taller. I'm like, President Trump, yes, you can lie about 10 pounds, but you're lying a little bit more than 10 pounds. I mean, I see your dress size, you are at least 40 pounds more than what you are reporting. My point is, we all do this. And why we are doing it is because of the perception of this issue and the social stigma that we discussed before. Even someone who goes to turn himself in with a private jet bigger than the Air Force One and with 300 people escorting him, he lies about his weight. All right, so we all do. And that's why when we bring this issue to see how realistic to utilize certain things, if you lie to me about your weight, and I tell you, I will always probably take 10 pounds, about 10 pounds off from my actual weight until I'm comfortable with where I am. So that means we still have this issue of come to our senses on weight loss, the morbid obesity issue. So my BMI is 28, right? My latest calculation, it may be a little bit lower than that now because I did lose, since I'm more strict on my diet. That medicine perhaps can be helpful for me to be going down by a couple BMI points. And it can help someone to speed up the process while they're going through bariatric surgery. And even after bariatric surgery, right, Dr. Irgau, because some patients do struggle with, not every patient has the same outcome. So we are supporting the idea, and we are happy that the healthcare industry now is more on board for the fight that we are giving for morbid obesity and the treatment option that we have. Bariatric surgery is the most important tool and most effective tool, and then yet the utilization is not there. And one of our goals also is to increase the awareness of how effective this tool is. Now, when we say comorbidities, we are talking about other diseases comes with morbid obesity, because morbid obesity is never by itself. There are situations that may be some exceptions, but when people have morbid obesity, usually they have hypertension, hyperlipidemia, they have diabetes, they may have refluxes, heart disease, sleep apnea, so many other problems comes with. And when we took care of the issue of morbid obesity with the most effective way of which is bariatric surgery, now there's an amazing result that we see, the resolution of these comorbidities. So that's where we actually want to kind of focus on today. Now, Dr. Irgau.
Absolutely, Kemal. So it's obviously a very, very important topic. You know, when we look at bariatric surgery, at what we do in our center, clearly and almost naturally, people focus us at the most obvious result of what we do, right? So people come very, very overweight with severe obesity. And once they've had the operation, you know, sometime later, that weight is gone. So the most obvious, the most visible result of what we do is weight reduction, right? Somebody who was very overweight, and you could obviously see that in their appearance. Now they've lost 100 pounds, they've lost 120 pounds. They were going to be looking completely different. That's the most obvious and the most outwardly result of what we do, right? But clearly, what we do is way more than weight reduction, right? As we've said it time and time again, and that is improving the health of the person, right? In a tangible way. And that's what we're going to talk today about. Risk of many illnesses related with weight, with obesity actually decreases, or illnesses that have already developed in that person will go away as well. It is interesting, actually, the last patient I had today in my office hours, around 1:30, a person, you know, who weighs about 285 pounds, and they would like ideally to be 150 based on their height. We were discussing weight loss surgery, the options, and they asked me whether their risk of diabetes will go up after they've had this surgery, right? I said, on the contrary. In fact, I want you to actually, if you have time, watch our session today on Bariatric Friday on YouTube, and I hope they are watching, because I said we will actually be discussing this very topic, what happens to certain illnesses related to obesity. So on the contrary, of course, rather than increasing the risk of diabetes after weight loss surgery, not only the risk of type 2 diabetes goes down, but also if a person already had type 2 diabetes, that is likely to go away or improve considerably. This is very important. It has really marked a shift in the interest of many doctors now referring their patients for bariatric surgery once they have discovered that it's not just about reducing the weight of the person, it's actually making them healthy as well, right? If you're a primary care doctor and you have a patient who is about 100 pounds, 150 pounds over their ideal body weight, they're going to come to you not only with the burden of that weight on their daily to-day life, but also with illnesses that are associated to it. So the likelihood of that person having type 2 diabetes is high. The likelihood of that person having high blood pressure is high. The likelihood of that person having sleep apnea is high. So as a primary care doctor, what would you be doing would be prescribing medication for each of those illnesses, right? Once you discover that actually those illnesses are closely related to the weight, then you will be going for bariatric surgery as the solution, right? Because once you address the weight, then you will be addressing those illnesses as well, right? And doctors really discovered this, Kemal, in a very clear manner when in 1995, there was a publication in the Annals of Surgery. That publication came from the University of East Carolina, and it was authored by Professor Walter Poirier and a team with him. And the title of that paper was actually much more unusual than most scientific papers. The title was, "Who would have thought it? ? An operation proves to be the most effective therapy for adult onset diabetes, which is another way of saying type 2 diabetes. And what they've done is, at that time, which is 1995, reported on a 14-year experience doing gastric bypass surgery. As you can imagine, in those days, gastric bypass was being done in an open fashion through a very big incision. And they were not doing all that many operations compared to our, the operations that are done now. In fact, over 14 years, they had 608 patients, which is the number of patients which probably we will do in a year and a half in our surgery center now. Anyway, what they've reported, Kemal, is that of those 608 patients, about 150 had type 2 diabetes when they came in for the surgery. And then when they followed them up after they improved, recovered from surgery, of those 150 patients, about 121 had total resolution of their diabetes, 82% of them. And because type 2 diabetes was supposed to be a chronic illness that never goes away until then, but then they have proved that this operation, gastric bypass, actually can cure type 2 diabetes. And the main purpose of their paper was to show how type 2 diabetes could actually be cured with this operation, but also they listed a number of other conditions that these patients had alongside type 2 diabetes that also improved, including high blood pressure, including sleep apnea, including heart disease, sometimes congestive heart disease, arthritis, joint pain that these patients had. Many women, young women who had infertility as they came in for the operation, their fertility level increased. So infertility was also being treated. And of course, since then, we have been able to reproduce these results with larger and larger study. And of course, we know from our own experience, when we see our patients coming in for bariatric surgery with all these medications for all these illnesses, once they have bariatric surgery and they start losing weight, we see improvement in these illnesses and increase in the number of medications that they have to take. Now, these results, as you know, Kemal, are quite dramatic. In other words, you could have somebody who has type 2 diabetes and they could be on many diabetes medications, including insulin, right, before the surgery. And then within about 4 or 5 weeks, we would send them back to their endocrinologist or their primary care doctor because the medication is too strong for them. Now their sugar is dropping too much, and their primary care doctor would take them off insulin within about 4 or 5 weeks of the surgery. And we've seen in situations where, particularly after gastric bypass, you would see patients get off insulin even immediately after surgery. So the impact of this operation on these illnesses is very dramatic in manner that is probably unseen in medicine before this type of surgery. I mean, it's very hard to think about any operation, single operation, that in one stroke is able to remove so many illnesses from a person who is suffering from them. So resolution of comorbidities, improvement in health, really, although it's not the most visible aspect of bariatric surgery, in many ways, it's the most fundamental reason why we do this surgery to begin with.
So, Dr. Irgau, when there are 2 case conferences I do every day, one is the bariatric, the other one is the primary care. And in the primary care, the goal or the focus is different. On bariatric, our focus is morbid obesity. So what I have seen, this is almost last 2 years. Just imagine, one of the medical schools, what makes you guys the great doctors, you repeat the same thing every day. But also every day while you are repeating the same thing, you are also seeing some variety and some new cases. And now you build up your experience and you become a great doctor, right? So on the doctor side of it, so it's almost like an education for us. So I have our nurses, our other business development team members, and we look at the patient from their chronic illnesses standpoint to see how this patient is being managed. Again, I'm on the primary care side. And for those patients who may have diabetes and hypertension and other problems, even if they're controlled, what we see is they're controlled with 3-4 different medications in each group. So then all of a sudden you look at this patient, and I do kind of like, that I don't, panic easily. But when I see like 7-8 medications that patients taking for 2 disease group, I'm thinking, well, there is a solution for this. And then usually we kind of tie that into the patient's BMI to see where the patient is. We are not saying that every patient with morbid obesity is going to have these issues, but most patients who have those illnesses do have morbid obesity, and they're almost on the borderline of being having morbid obesity and morbid obesity. So having 7-8 medications every day, multiple times, it's challenging, right? So you have to really go through this, and it's not the best way. These medications do have a lot of side effects. I think the worst side effect of the surgery is the excess skin for those who lost 150, 160 pounds, right? So, but that's okay. We have, we can figure that out. But this is when you live with those chronic illnesses for so many years, you only live so many years. So things are not happening after a certain time, and you actually end up your quality of life is decreasing, and your life actually is decreasing. So now when we look at the resolution, as you were highlighting, but I want to give some numbers. We are not talking about like 10% or 20% resolutions on these issues. When it comes to diabetes, we are talking about 83% of the patients who whose diabetes is resolved. With the cardiovascular disease, 82%. With sleep apnea, that anywhere from 74 to 98%. Hypertension is 72 to 94%. And these results are extremely impressive. And that's one of the things that we want patients to understand. Again, like every time we discuss these, we know there are other issues, not just treating the clinical problem, but there are social stigma of it. There's other psychological impact of having this surgery. But main thing is knowing how effective this is the key. And now, if someone says, "Well, I don't have any of those problems, so what's next?" Well, you may not have those right now, but they're going to develop in time. But one of the biggest also issues is the joint problems, right? So like when you have to when you have to live with that weight for so many years, then your joint issues are going to come up. So then it's not like we are saying that you should only do this when you have these problems. We are just saying that those are the benefits of having the surgery, because the main issue of getting someone from 380 pounds to 200 pounds in 9 months, that's a huge impact in their life. So one of the things that I also want you to kind of elaborate for us is in some of our discussions this happened, the cancer, the impact on cancer, how the weight loss has impact on the cancer, if you can actually address that for us.
Absolutely. So really, with the increasing incidence of obesity in our society over the last 3-4 decades, especially, we have also seen an increase in a number of different cancers, right? We're thinking that our fight against cancer was having the upper hand because of improvements in detection, because of improvements in the treatments, and also because of the preventative work that was being done at a population level, whether it's mammograms or colonoscopy. Then at that time, we were also seeing an increase in the incidence of these conditions. And that seems to be related to the rise in obesity as well. In fact, there have been a number of publications come out that have really demonstrated that there is a correlation between certain levels of obesity and a number of cancers. And that number of cancers is actually growing meaning that we are finding that many organs that are involved in a specific type of cancer, that risk actually increases with obesity as well. So when you look at studies that have followed up patients that have had surgery to reduce obesity and patients who have not had surgery and they remained obese or morbidly obese, you can see clearly that the incidence of cancer is much higher in those who did not have the surgery to reduce the weight. So there is now this association. Obviously, we don't understand clearly the mechanisms by which obesity puts a person at risk for the development of certain cancers, whether it's uterine, whether it's breast cancer, colon cancer, kidney cancer, right? But regardless of the mechanism, the data at the population level shows that obesity has a clear correlation with incidence of a number of cancers. And this is obviously very concerning, Kemal, because if you look at the cause of death in our society, you are really looking mainly at things like cardiovascular disease, like heart attacks, high blood pressure, and strokes. You are looking at conditions like type 2 diabetes, and then you're looking at cancers. This really make up the majority of the causes of death in our society. And guess what? All of them seem to be correlated with the incidence of obesity as well, which means that if we are able to tackle obesity, we are able to reduce drastically the appearance of these illnesses and therefore have an impact on the longevity of our population as well. So that the life expectancy of the population will actually stay higher and continue to increase if we have an impact on obesity. Unfortunately, we see, as you know, Kemal, even though bariatric surgery is the most effective treatment that we currently have for severe obesity, it is accessed only by a very small minority of patients. In other words, the people who end up having bariatric surgery are a tiny fraction of those who would be eligible for bariatric surgery, which means that we're not really reaching the largest number of people who need our help, which is that we may not have impact on this life expectancy. And for the first time in our history, we may have a generation that lives shorter than its previous generation. In other words, the life expectancy over the decades has been increasing steadily because of improvement in health. But for the first time, this generation actually may die earlier than their parents because obesity is making all these illnesses appear and cause early death in the population, essentially. So you're absolutely right. It's not just about the comorbidities that we're talking about, the type 2 diabetes, the high blood pressure, the sleep apnea, but also the appearance of cancers. And that is obviously of great concern.
The other issue that many people also maybe not seeing this as a main problem when we discuss the morbid obesity is the depression and anxiety related mental health related issues. So mental health is one of the biggest issues in the society that we live in today. And yet there's not much we can do other than medicating people or even for the therapy, not enough providers available out there, or not everyone feels comfortable going to those sources. And what we see in our patient population with those who are dealing with morbid obesity is depression rate is so high. It kind of actually makes sense why they would, because there's a lot of body shaming, society, pressure. And I'll give you a funny example. And I sometimes share my ups and downs with my weight issues. But the other day, my dad told me that I have to lose 35 pounds. I'm like, what? Like, I thought I already lost, some. And he really just bluntly just said that you need to lose at least 35 pounds. I'm like, the way he said it was rough, tough, but you have to kind of take it. So then that day, actually, when we were at the surgery center, I went to the scale there, and I'm like, let me see if he was right. You know how we lie about our weights all the time, and we discuss, and then I'm going to make a correction from our last week's event. So when President Trump reported his self-reported his weight at 215, he's not less than 280. No way. So, but my dad was right. So the scale doesn't lie. So then all of a sudden I had this, like, I panicked a little bit because I was doing really well with my diet and walking and everything, but it's a slow process. So slow process in a way that I can afford going through that process because my BMI was never over 30. And where I'm comfortable is usually 27. And I can get to that if my dad keeps reminding me how much I need to lose. But when we discuss, because our patients are not in the same situation, they have to lose 150 pounds. How do you do that, right? So now that's the depression part. I understand very well because it's depressing when even just hearing it. When he told me 35 pounds, I'm like, oh my God. Like, and then when I went on the scale, I'm like, I was even more upset because he was right. So this is if I have to live with this for so long, then depression is going to build in a way that because it's not going to be limited to that. It's going to be affecting my interactions in society, like whether I want to socialize with others, I want to go out, self-esteem, everything else is going to be, and all of a sudden you have that chronic depression where, again, if we take care of if we go to the root of the problem, we can actually see so many great results on different illnesses that morbid obesity is related to. As our patients are going through a long process prior to the surgery with the screening that we have in place. So this can be anywhere from 2 to 3 months. And so many different appointments are already completed. Now it's time to have the surgery. So prior to the day of the surgery, we have a surgical clearance appointment. That's usually 2 weeks before. And then that 2 weeks is usually patients are with the special diet, with the new direction diet, so which helps the liver to get smaller, and that's going to make the surgery less. It's going to decrease this complication issues. So then we are already pretty much in touch up to the point to the surgical clearance, and now we want to kind of cover the day of the surgery. So, Dr. Irgau, what can we expect, and what should we be looking for on that day?
Absolutely, Kemal. So I was actually driving back and listening to your previous session, and you were introducing the topic for today, and you mentioned the fact that for many patients, emotionally, this day is a mixture of emotions. On the one hand, they are obviously anxious because they are going to have surgery. And on the other hand, they are excited because it's the completion of a long journey that they have started perhaps months ago in order to undertake bariatric surgery to treat morbid obesity, which for many has been essentially a major problem, not in terms of their quality of life, the burden of the weight itself, and the struggles that they've had over the years trying to shed it, but also from a health point of view, many of them will have started medications really that are directly for diseases that are directly related to the obesity. So it's an important day from that point of view. And that mixture of emotions is actually completely normal and expected. And that's what I tell our patients when they tell me that as I approach them in the preoperative area before the surgery. So it is useful to look at the day of surgery at our bariatric center, at the American Surgery Center, in 3 phases, essentially. There is the preoperative period, there is the actual operative time, in which the patient will be completely asleep under anesthesia. But then there is the post-operative recovery area in the surgery center. And as you mentioned, this all occurs within a single day, essentially, as the vast majority of our patients are actually operated on at the American Surgery Center as outpatients. In other words, they do spend the first night after surgery at home rather than within the center. If we do need to keep them overnight, of course, we have the capability of doing so, but we haven't had the need to do so for actually probably a couple of years now, if I recall well. So starting from the preoperative time, they obviously arrive at the designated time at the surgery center. And many obviously will have had instructions from our surgery center, perhaps the day before or a couple of days before, about exactly what to do before coming to hospital. And one of the things we ask them to do is actually to take a couple of extra strength Tylenol tablets at home with a sip of water before arriving to the center. Now, this sounds counterintuitive to many, saying I have to take a pain medication before the actual surgery, but it does make a lot of sense. Perhaps the most important development that we've seen in surgery, Kemal, particularly in the way we perform it, is enhanced recovery after anesthesia. In other words, preparing the patient to have the least discomfort possible after the surgery so they can be up and about very shortly. In fact, we wouldn't be able really to accomplish what we're doing right now, sending patients home after major surgery the same day, if we didn't have this protocol in place, which allow us really to control pain very, very well, to control nausea very, very well, and to get patients really to wake up from surgery fairly quickly. So they take those two tablets, in other words, as part of the priming of our body to have less discomfort after the surgery. So they will take those two tablets with a sip of water, and they will come to the center, and after being registered and enter the preoperative area, they will have an IV started to have antibiotics and other medications. One of the more important medications that is administered in that preoperative period, Kemal, is a medication to minimize the risk of blood clots. It's a blood thinning medication that is injected with a tiny needle, either in the belly or on the thigh of the person. And usually this occurs about an hour and a half to 2 hours before surgery. And when we do that, we decrease considerably the risk of blood clots, which used to be the bane of their existence to our predecessors who saw, 20, 25, 30 years ago, a very high level of blood clots after surgery. But we're able to minimize that in part by doing that, and in part by applying special boots on the legs of the patients, again, in the preoperative area or in the operating room, so the circulation in their legs is happening, although the patient is immobile because they are under anesthesia. So important preventative measures that we have adapted as a protocol, and all our patients will go through that. And that's part of the reason we have excellent outcomes and high levels of safety in our surgery center. The patients obviously will be seen by our anesthesiologist, who, by the way, will have seen the medical records of our patients days before, but they will be meeting the patient at that time to explain more about what anesthesia entails, and also to set the expectation of the patient in terms of what will happen in the operating room before the surgery as they go to sleep, under anesthesia. After that process is completed, and that can take an hour, it can take 2 hours, and sometimes a little bit longer, the patients will be going to the operating room, and they will have met all the operating room staff. They will have met the nurses, which is great, of course, the anesthesia team. Of course, they've met their surgeon and know their surgeon for some time, but they will also meet the scrub tech, the person who will be helping the surgeon at the time of the surgery by preparing the instruments that are needed for the surgery. And then last but not least, they will also have met the surgeon's assistant, which in our case is actually Stephanie Cavalier, who is our physician assistant, and they will have met her as well before the surgery. So they will have met all the members of the staff who are dedicated to the surgery for that day. So that patient will be the center of the surgery center's attention during that time. We specialize in bariatric surgery. That's what we do. So bariatric surgery is not just one of 10, 11 disciplines that we have, like it may happen in the hospital, but that is really what we do. And the vast majority of the staff within our center are really tuned in to the bariatric patients in our center. So what happens at surgery? Most of the surgeries will take about an hour, maybe an hour and 15, sometimes an hour and a half. That's really the length of the actual surgery from when the surgeon starts doing the surgery and then complete all the steps of the surgery. And then the patient will be rolled back to the recovery area.